Remember, your jaw is a dynamic system which has to do with your neck and your back muscles and your posture. So there's a direct correlation of your joint and your muscles and your neck and the posture that you have. If the dentist understands occlusion, understands the TMJ, understands what's going on, you're not gonna have problems. It's when they don't. And it could be in America, it could be any country. It doesn't matter where you are. The point is to understand it, diagnose it, take the CBCT scans, and listen to the patient. The patients have all the information. You gotta get it out of them. They don't know what's important.
Talking Teeth with Dr. Dean.
Welcome back, everybody, to Talking Teeth. This is episode number 11. I'm very excited here to come back and talk to you about this wonderful topic. Our topic today is TMJ, the joint, the grinders, people who are wearing night guards, anybody who's clenching or bruxing. This show is about you, and we're going to talk about the prevalence of TMJ pain and what's going on in the dental community. I have my very close friend, Dr. Publio Silfa. Let's hear it for Publio from Long Island. And a special guest here, Yuliana Bravo, who is an experiential expert on marketing and private membership for all high-end things. So welcome, Yuliana, for us. She's been with us for 18 years as our beautiful PR lady. So welcome back, everybody. We missed everybody. I hope you had a good summer. And let's get right into it. First of all, TMJ is a 33 million people problem. 33 million people suffer from TMJ, from mild TMJ to severe TMJ. Mostly are about 65% are females and the rest are males. And also a lot of it has to do with orthodontic treatment when they were younger. So there's a direct correlation with orthodontic treatment. Not for everybody, but most of them. Many people have an orthodontic component to that. So in our office, when a patient comes in with TMJ pain, we start to analyze him or her. What we try to do is figure out structurally what's going on with the joint, and that's the only way to do that is by taking what's called a cone beam or a CBCT scan of the joint and the area and evaluating what the position of their teeth are. Now here's the major problem. The teeth sometimes are in the wrong position because the patient has been grinding and they lost their bite, so to speak. People say, I've lost my bite, I don't know where I'm biting. The continuum of that over 10, 15 years will cause the joint to start being deranged and out of position. That's most of the patients. Other patients come in because they either had orthodontics or maybe they had an accident. That's another very high prevalence if they had an accident. Like Yuliana here has experience, that's why I have her here to talk about that. So in accident cases or somebody falls, all of a sudden there's a misalignment of the joint and that process starts. Now again, some people may have it in a mild sense, it kind of hurts a little bit, and then there's treatment for it. Now the good news is it's not a surgical treatment, it's usually a manipulation treatment, massages, chiropractors, TMJ dentist. Obviously we have a TMJ dentist here, Dr. Peter Farrow, who's been doing TMJ for 40 years, so he's an expert. A lot of TMJ dentists have only been around for 3 or 5 or 10 years, and that's an issue because they don't have as many experience. You want to go to somebody who has many years experience and knows how to handle all the problems. So, Publio, where do you see in your practice with the TMJ patients?
Very, very, very common in patients who are coming back to try to do orthodontics again because they had orthodontics when they were young. Very common in 30, 35-year-olds, and many of them, they don't even know they have the TMJ problem, right? They hear the click and the pop, right? And some of them have no pain, but some of them are expressing pain, but they didn't know if it was normal or not.
Right.
That's a very common spot that I see.
A lot of people say that it's okay, you can go ahead and live with it, right? Some people say it's okay, it's gonna get better. Some people just take medication.
Yeah.
But the clicking and the popping is a real thing. When patients have a click, again, it has to do with the tendons inside, and whether they're in pain or not, right, is going to make a different decision on how we treat them.
Yeah.
So the really key point to understand is TMJ can be treated in many different ways for many different people. The symptoms are very specific for each patient, and the cause is very specific for each patient. And I know, Yuliana, you went through that with your accident. So how did that affect your life?
Oh gosh, I couldn't eat. I was in constant headaches. I barely could speak. I was just in constant pain. It was excruciating.
Right. So you were in
So-
severe pain.
Correct.
And was it right side or left side or both?
It was both, but mainly from the right side. There was a disc that was so dislocated, they thought that it was torn.
Oh, wow.
So it was because you were my first visit, and
Right.
you helped me at least have some relief.
Yeah, so the first relief, the first kind of treatment that we do with most patients is a bite plate or what's called a night guard. So bite plate, night guard are kind of like the same
They're very
thing.
similar.
Very similar, just different terminology. How do you feel about it? Because I know some dentists use hard bite plates and other dentists use soft night guards.
So
how do
I,
you-
I do the combination. I'll do the hard shell, which is the outside hard, but the inside of the teeth where the guard engages,
Right.
more of a softer
Okay,
material.
which one did we give you? I don't
It was the
remember.
hard.
You get the hard one, and it helped you initially just kind of
Correct.
get some
Just
relief.
at night specifically.
Yeah, yeah. Now some people, again, they're talking, and their job is a lot of conversation, and you can't wear it. You can't wear it all the time. The real prescription is to wear it all the time, because as the joint is in a position of the bone and the articular eminence where the cartilages are, by putting a biplate, putting some kind of appliance in there that separates the teeth, actually separates the joint away from the actual tendon. You can look it up on the internet, the actual position of the joint. But the biplate acts like a protector of the teeth and also opens and changes the position of the jaw. And now it moves away from the bone, so any kind of irritation or structural touching of that bone is now separated.
Separated.
And that's where the real relief initially starts.
Yeah, that's when the process of the inflammation factor calms down because it's no longer constantly pressuring. So that's the benefit of the biplate. It gives the patient to put its joint back in position, in a more relaxed position.
Right.
So the muscles are not tense. Also, they're not activated as the biplate's on. So it gives that opportunity to.
And then what happened after you had the biplate? Like, what was the succession of your treatment? How did you go through that?
Well, my teeth were. I heard you saying how where's your bite?
Yeah.
So I was like, oh wow, I remember that.
Yeah.
And it was also because it was like my jaw was not in position per
Right.
se, so there was like some misalignment there too. And so it took different stages,
Right.
redoing the bite plates and the night guard, physical therapy, and also going through different treatments for the TMJ. But it was definitely going back, resizing, refitting, and then getting used to it
A
as
lot
well.
of people always also, I find, they start complaining about neck pain or ear pain, right? Or like you said, clogged ears sometimes. So that's definitely related. Remember, your jaw is a dynamic system which has to do with your neck and your back muscles and your posture. So even on another note, from the player's perspective, a lot of players wear guards to give them more stability when they're running, jumping, and doing their sports. So there's a direct correlation of your joint, your physical joint, and your muscles and your neck and the posture that you have. So yeah, an accident is definitely going to kind of take that off position and then start the process of that and starting having the pain. Again, it could be mild pain and then it gets better if it's more of a muscle situation, or it could be more if there's damage originally. Another thing I found is the patient doesn't know they have a TMJ problem until something happens.
Yeah.
So something triggers it sometimes. They have a structural problem, and then either accident or maybe even a crown, or they're sleeping funny, or they fell, and then it really hurts. And they're like, how did this happen? And I see the joint. We take a picture in a CBCT of the joint, and we see this is not an acute problem. This has been a chronic problem for many years. So a lot of people don't even know they have that.
Yeah. And you made a good point. You mentioned players. You mentioned how accidents trigger these pains in TMJ. So let's say a patient comes in with TMJ problem. What do you firstly recommend them? Do you send them to a TMJ specialist? Do you send them to a physical therapist? Do you send them for acupuncture? What's your approach to starting treatment?
For us, there's three answers to that question. The first question, obviously, the answer is we're giving them a biplate and seeing what happens in 4 weeks, 6 weeks. That's like your first test. Is the night guard and the appliance going to help them initially? If we get initial response, that's a good sign. That means it's a muscular thing. It's not a structural thing. if we see something structurally wrong with the TMJ, now we have to start making decisions. The TMJ doctor, does he treat the patient first? The physical therapy together. Maybe they're going to work together.
Yeah, it was.
With the chiropractor too. So it really depends. So the answer to the question is, what is the patient presenting with? What's the history? Right? You got to listen and ask the question. I think the biggest mistake dentists don't make, and patients don't ask, hey, I had orthodontics at 16. I had 3 sessions of orthodontics at 16, 18, and 21. That's a big piece of information that's going to cause the teeth to be moving their whole lives. And it's going to be shifting. They never get their bite.
Yeah.
So we see that a lot. I want to talk about something that a lot of people may have had many years ago that are living now with it. I'm talking about premolar extractions. Premolar extractions was a thing 25, 30 years ago. They were taking out the premolars for the kids because they didn't have enough room. And they would put them together, and they would be without their 4 premolars, and their teeth would be connected and all together in, which created a lot of tension on these patients. Now I'm seeing at 40, 50, 60 years old, I said, they took out your premolars. Can we talk about that? Like, that was insane back then.
Yeah.
Sorry, orthodontists, I don't know who came up with that, but today we strip the teeth and we make the room. So that was a problem back then. I mean, sorry, it was a thing back then. It's a problem now for us because we're dealing with it.
Yeah.
Talk about that.
Well, I see the consequences of the sunken face. The patient smiles and they can't show their teeth because the teeth are so back in position. The position in which how they occlude, right? The way their muscles allows them to chew are not as ideal as if they had all their molars into place. You know, those are factors that I see side effects to that. You know,
Big side effects.
You're looking at someone and smile and they can't seem they don't seem their age. Their facial structure completely is sunken. They look 20, 30 years older. You know, just the way when they're young, well, all the muscles around the lips are tight, right? It's normal. But as they age, the muscles loosen up and then they start.
So do you make your appliances in the office?
We do.
And do you make different stages, or you make 1 or 2 stages, and then at one point do you say, okay, it's not working, you know, we have to send you to the next level?
I evaluate the TMJ patients first. If I see that it's a very advanced TMJ case, I would refer out immediately because I want the patient to get stable as soon as possible. But if someone who has a very minor relapse, very tender, starting initial phase of TMJ, I will start with the biplate.
Yeah, so how long did it take you to get better? Like what was your process after your initial therapy and then your physical therapy? How long did it take you to kind of get better?
You know, well, like you mentioned earlier, it's like you really want to get to know your patient, and every case is very different. Like for me, I mean, I had a mild TBI, neck injury, shoulder, like I had multiple injuries, but because, you know, many doctors are not like what I experienced here, where actually they know you or they dig deeper. It probably took me over a year, really, to see some relief, to be able to start eating a little bit more normal and they start not feeling pain.
If you can't even eat with the pain, that's even worse.
Oh, it was awful. Yeah, I couldn't. I think I started chewing gum maybe like at, oh my God, maybe close to 3 years.
Right.
Really, again, I had so many other injuries.
Right.
But just the fact that my jaw and my mouth and face and head hurt, it was constant.
And what was the moment that you said, I feel better? Like, how long was that?
Where I like really felt better?
Yeah.
I would say 3 years.
3 years.
Yeah, like 2.5 years into the third
good
year.
news is, here's the good news. If you have the right doctors and people are listening and asking the right questions, and you get the right orthotic to put you in the right position, the joints, every joint that we've seen here has remodeled. Every joint that's been damaged has been remodeled. That's the way the body works over there. We even had a patient who was very young, 22-year-old, who broke both their condyles, and the bone that was left recreated their joint.
Wow.
So the body really heals, and that's the good news. I think the real message is, one, figure out if you're grinding, because grinding is a different problem. It's not really a TMJ problem. It's more like a structural problem of sleep and sleep apnea, and they're just clenching and they're grinding. And sometimes we see them, they wore all their teeth down, but there's nothing wrong with their joint. So how does that happen?
It's to me, I don't know, because it's not my forte, it's a specialty, but I ask myself, how does the patient get to a point where their teeth are grinded down, but they have no TMJ?
We're gonna go through that one.
You know, so it's definitely, you know, that wear and tear over time, the teeth erupt, and they kind of maintain that position where the joint still doesn't suffer. But sometimes we've seen it the other way around.
Well, when they wear their teeth and the joint gets hit.
And then the joint gets triggered.
Questions? What do you have?
So let's say if I didn't go through an accident,
Right.
and so forth, how would someone know they have TMJ?
Well, obviously pain. I think a lot of people have it, they don't know they have a problem because they have no pain. But I think once they have pain, they're going to say, hey, you know what, I got to take care of this. Now, there is a big group of people that they're staying in pain. And I see them, let's say 5 years later, I said, how long have you been in pain? Oh, I've been in pain 5 years. Why didn't you take care of it? So that's like another thing. Like they just either don't have the time or the money, and they don't want to really kind of take care of it. Meanwhile, that's causing a lot of damage. TMJ, if not treated, will cause more damage. It doesn't get better on itself. It's got to be intervened.
Yeah. What's your take on Botox and the treatment?
Oh, so that's been a big issue. The Botox craze has leaked into the TMJ world. The concept is we're going to put a little Botox to relax the muscles.
100 units on each side.
100 units on each side. Now the muscles relax. And what happens? They can't clench. So all you're doing is putting a Band-Aid on it. Now, some people, they feel great. I mean, they're in a lot of pain.
Yeah,
so
6 months.
It's
They're
okay.
good.
It's okay. You know, I have nothing wrong with it. We personally don't do that. We send it out if it's an extreme case. But those are only the times we prescribe that is when they're really in a lot of pain. They can't go to work. And we say, okay, let's get some Botox in there, give them some relief, and then go ahead and figure out the problem. But that's been coming more like, hey, you're doing my Botox on my lips. Go ahead and put some in my joint too, so I can relax tomorrow night. I'm going to a party. So yes, it's a reality that we deal with. But again, we don't really prescribe it unless it's an extreme case.
Yeah, that's the same scenario for me.
But some people are running. Give me Botox.
No, I mean, I remember that phase but they didn't really inject me with the Botox. They did. I think I probably had one session on the cheek, and sure it was relief, but then it was more focused up here, which has nothing to do with cosmetics or anything like that.
Well, again, now you have to understand something. When you have something in your one tooth, one filling or a crown, and your muscle, it's called a mastoid. There's about 12 muscles in the TMJ, including the 3 or 4 ligaments that are there, which is a board question, which I just remember. But if there's a tooth in the wrong position, your muscle is going to tense, and that's why the temporalis muscle starts firing, and then that becomes a different type of pain, and then that can go into a migraine pain. So it can really expand. I know you've experienced that too. So it's a real issue. Next question.
So what happens if I have clicking in my joints?
Clicking with no pain, with no damage, is just a functional part of the ligament, which means that you could wear a bite appliance to relieve it. Like, you just don't want to hear the clicking. The other problem that happens, people have a big bite of a sandwich and they can't close. They get stuck. That's another problem. Basically,
overextending.
They're overextended, and the way the joint's made, there's tendons. So if they overextend it, the tendon goes behind the joint, and then they get locked in. They got to be pulled down and out.
So you should listen to the
click. You pull down and out, and then you can release it.
So you should listen to the clicking to avoid from.
The clicking is the starting point, and some people have it for years. They say it doesn't hurt me. Again, it's just a diagnosis to figure out, is there a problem physical with the joint, or is it just now a noise that's happening from post-ortho? Those clicking noises, 90% had orthodontics, because the teeth got moved. Remember, when you move teeth, things shift. The joint stays where it is. The teeth are in a different position. The patient closes for 10 years from 15. Remember, 15 to 20, everything's adaptable. But now you get to 25, 30, 35, get married, have a couple of kids, all of a sudden the stress is there. Talk about that. What is the stress involved in TMJ?
I was just
Not a
thinking about that.
clenching.
Is there anxiety-related TMJ disorders? Is it stress-related? We talked about patients who clench and grind. Yes, the teeth wear over time. The problem is, or the situation is that many of them don't get the pain, right? They get to a point where there is wear and tear on their joints, but they don't have the pain. And the question is, how do you manage that? You know, the patient comes in and they want to do veneers. They want to do a full smile makeover veneers. Doc, my teeth are short. I'm like, yeah, now we have to look at your TMJ to see if it's possible that we could open your bite, raise your bite, create the space. Because doing those changes, what happens is that patient thinks it's easy, that they're going to get 6 veneers done without opening and changing their bite. But because they have the TMJ, now they're in a challenged position that we can't open their bite because the joint is going to move.
Yes, but how many times did it happen when the patients are coming in saying, I want to do my treatment, I want to do my smile makeover, I want to change my bite, you're the best dentist, I want to come to you, and you're like, wait, I can't do this.
I can't touch it.
Yeah.
Because, you know, you see the positions are wrong.
Yeah.
So how many dentists aren't noticing it or
Yeah.
are too unexperienced to notice it?
Even I have to.
How do you teach them? My point is not to say they can't do it. How do you teach the dentist or the patient to ask the right question?
I think it goes with the practice and the numbers. Like, I remember one of my first cases, I tried to restore a patient who was grinding, and the veneers and the temporaries will come back in their hands. They're breaking, chipping. And I'm like, why is this happening? And then I had to identify that there was a gap of space that needed to be open so that the teeth could be in the right position so that the patient could move freely. I'm like, okay, now this makes sense. It's
Right.
not 6 teeth that I'm trying to fix. Now I have to change the entire complex,
Right.
the environment of the top teeth and the bottom teeth. So that's when I realized it's not just about the teeth, it's about TMJ. It's how about fixing the TMJ first, getting to the patient to a comfortable position, and giving them the smile they want. You know, and like, how did you learn that? Like, of course I learned that with occlusion, FMR, teaching, but I learned that from my mistakes that I did at the beginning.
Right.
Now I see a grinding patient, first thing I do is CT scan. Where's the joint? Okay, I can't open the bite because his bite is in a good spot.
Right.
Now we talk about crown lengthening, now we talk about bone reshaping, because and then the patient, in their eyes, they want teeth, but they don't understand what's happened in their mouth to get to where they are.
So they see the end product. And
Yeah.
that's
Yeah,
They
they want the
just
end
want the end
product.
product.
And as a dentist, I'm like, all right, I got to give you what you want right now. Like, no, I got to
Yeah.
give you what you need.
Right.
And then we'll get you what
And,
you want.
but I want everybody to remember, the TMJ joint is a multi-movement type of joint. It's a 3-dimensional, 360-degree moving kind of part in your body, whereas all your other joints are one-directional. That's all they do. This is a multi-left, right, up and down, cross, and comes out. It disarticulates. It actually comes out of its position for you to eat and to yawn and to, you know, do whatever you have to do with your mouth while you're eating and talking and yawning. So it's a different type of joint function, and that's why there's so many muscles attached to it, and that's why the pain can go up and down in different areas if there's something wrong. So our position is to find something, whatever it is wrong, and then try to fix it.
Yep. I'm gonna throw you a wrench.
Go ahead.
When these patients that have the joints moving in different locations and they have multiple bites.
Oh. Please don't tell me you have 2 bites. And I tell the patient, please close. And they say, which side should I close on? I said, just close. They said, I have 2 or 3 bites. Tell me which one I should close to. Right away I stopped. I said, no. We can't do this. Can't do this. We got to stabilize where you are. There's a reason that you have 2, 3 bites. And they know it. This is the crazy part. They actually know, Dr. Dean, I have 2 bites. Which bite should I bite on? So that becomes very frustrating when you're trying to put a tooth in or a crown or a filling, and they're just biting in all different directions.
Yeah, their wear is like a roller coaster. So they have the teeth on the bottom and the top, they go like this. So when they bite, their teeth are actually molded to that specific bite. And then they bite again on the other side, they're molded on that side. So it's
like 2 rocks rubbing each other, and then you have 16 rocks rubbing each other.
Yeah.
And now it's all in different positions, and they say, I just need 1 crown. Like, I don't know where to put the crown.
Yeah.
Oh wow! And they don't experience. This is part of TMJ.
They are correct.
Sometimes
Yeah.
they don't have pain, which is worse, because if they have pain, they have a motive, right? If they don't
Yeah.
have pain, they don't have a motive to change anything. So it becomes a little difficult for us to help them.
The motive for that dentist who starts restoring these patients starts happening when they see that the first veneer pops out, the second veneer pops out, the third, because it goes as a roller coaster. Like the first line on, like a domino effect. It goes like a 1, 2, 3. Like, wait, I fixed this one, now this one breaks. I fixed this one, now the other side breaks. And that's when we learn what the occlusion is and how it needs to be restored.
I have a question for you. How many times in this year, just let's say this year alone, did a patient come in and say, I had my teeth done in another country and they broke or they chipped? Dr. Publio, please help me.
I see that very often, and that's the price they have to pay for medical tourism, dental tourism, that they have to then solve the problems when they're away from the country they did the work on. But yeah, many times it's all about the occlusion, the bite. Teeth look pretty. Teeth look pretty, but it's just that the background is hitting, then the front tooth hits because they are not in a proper alignment. And
now listen, I've seen some beautiful work out of some great countries. I mean, if the dentist the point is the dentist got to know, right? It doesn't matter where the dentistry's done. If the dentist understands occlusion, understands the TMJ, understands what's going on, you're not gonna have problems. It's when they don't, and it could be in America, it could be any country. It doesn't matter where you are. The point is to understand it, diagnose it, take the CBCT scans, and listen to the patient. The patients have all the information. You got to get it out of them. They don't know what's important. Orthodontics, Invisalign. If we talk about this Invisalign, online Invisalign,
the DIY,
the unmanaged and uncooperative visible braces that people send out and get their teeth, and it's unsupervised.
I just
and
had
their
a
teeth
patient
are
like
moving.
that.
This is $1 million business. The company went out of
Yeah.
business.
Sounds like a disaster.
The company went out of business, obviously, because you can't do unmanaged orthodontics. Orthodontics is hard enough to manage when you do it right. The point is, when the teeth are moving in the wrong position, that's going to be another joint problem. We have patients like that who had the wrong orthodontics done, and now the TMJ is hurting them, and it's just terrible. It's terrible.
Yeah. You just brought me a memory. I had a patient one time comes in, beautiful smile. I'm like, why is this patient here to see me? He has a beautiful, nice and straight teeth. He smiles, but when he said, Doc, I can't even eat a pizza, he bites down, his back molars were hitting. So all the front teeth were open. There was a gap in the front teeth. Every time he tried to bite the pizza, he could not. I'm like, how'd this happen? I'm like, I ordered online how to do Invisalign, and he was doing Invisalign, or not Invisalign, but a clear aligner from home.
Right.
And I'm like, no, impossible. But yeah, that's the price they pay for making those.
Yeah, so fast work, right, is a problem. Like when I just want the aesthetics, I just want it to look good.
Taking shortcuts creates long cuts.
Yes, you need a strong foundation.
Any other questions? Are we good?
So let's see. You mentioned, ages.
Oh, so the age group that I find is 32 to 60. And I would say 65% women.
Why do you think it's women?
I don't know. I really don't. I don't have a theory on it. Why would be more women than men? Maybe men just tolerate it. I don't know. I don't know why the prevalence is higher on women. Maybe that's because they have children. They've stressed out. I don't know what the theory would be. But there's definitely a higher prevalence of women. And the point is, again, to find the right dentist, find the person who understands, get the right information, get the CBCT scan of the joint, make sure there's no functional problem, and then start with the bite therapy as a minimum, and then slowly find the right dentist. If it's more extreme and more dangerous, then you have to have a team. I think a team is the best way to go. Have the team of the chiropractor, specialist, orthopedic, TMJ dentist, and then, everybody working together.
So you mentioned experience, and I was very fortunate to have the right team because I knew you. Right? You were my dentist before, and I had the situation. For someone who may not have a trustworthy dentist and experience something like that, come here. Yes, for sure.
Call the office. But even if
what do they look
even
for?
if they can't come
they're
to
in
New
another
York,
state. They're
we
somewhere
have
else.
dentists around the country, around the world, that we have a team of over 350 dentists around the world that know what we know and talk about what we talk about. So yes,
Yeah.
anywhere, any country you reach out to us, we'll have a referral, no problem. Thank you for
No,
that.
that's great.
Thank you.
Thank you, everybody. We'll see you soon. Next episode coming up about cleaning your teeth, how to clean your teeth, the right way to clean your teeth, and the best toothbrush that's now available and the best toothpick that is available. We'll be coming up with that next time. See you soon. Thank you, everybody. What's our time? That was great.
What happened to? Was it?
That was good.